Don't rush in on scenes if there's any signs of chemicals involved. So make sure that, and if you do go on to scenes like that, that you're wearing the proper body and respiratory precautions that you have. In today's world of COVID, everybody is wearing masks anyways on scenes. At least quite a few are still wearing masks. So moving on to crime scenes, potential crime scenes, be aware of that. Be aware of the environment that much more, because you don't want to disturb anything that you don't need to. Because anything and everything could potentially be evidence. You're not going to want to rush into a potential crime scene either. You're going to want to make sure that law enforcement has entered that premises first, made sure that the scene is safe, and develop an escape plan. An escape plan is going to be a little different from your egress or from getting a patient off scene safely. Your escape plan is if you have to run. Make sure that you guys know what your exits are and that you can get off the scene fast. This goes back to the scene being safe currently. Doesn't mean that the scene is going to be safe the entire time, especially if you're in an area that's known for violence. Be aware of bystanders being present. You don't necessarily know what their intentions are. And specifically, it mentions patients that abuse methamphetamines can be a serious threat. I worked in Iowa for 4.5 years. A lot of meth use in the state of Iowa amongst certain patients, and they can become very violent very fast because they are very unpredictable in their behavior and their attitude. They can be calm and compliant one moment, and then the next moment they're quite violent. So don't hesitate to have a rider come in with you, or to have a law enforcement officer come in with you. Make sure that the patient is restrained appropriately, and make sure that the patient is restrained face up in a supine position, never in a prone position. The only reason I say that because of the date of this recording, which is January 12th, 2023, there was a major incident involving some medics in Illinois where they transported a patient prone, strapped him down prone, and he wound up dying. And that is absolutely unnecessary, because we will tell you from day one, the teaching has been there for years that we do not transport patients in a prone position. I love this picture. I love this picture because this gives you a great opportunity to just take this in, because you could pull up on this scene easily if you live somewhere more north, I suppose, where there is snow. But you have plenty of scene safety issues here. You have an unstable surface, snow and ice, sleet. You can want, this is going to be a difficult patient to get to and a difficult patient to get off scene. It could potentially be raining. It looks like it could snow or rain based on this scene. Vehicles around you. Think about why this car got into an accident in the first place. Did it lose traction on the road and slide in there? If there's cars going by, they could wind up having that same thing happen and slide off the scene and then potentially coming near you, and that's not good. So consider the stability of the structures around you too. Are there light poles, electric poles involved here? Looks like you hit a couple trees. Are the trees stable? Is there a potential risk of a tree coming down on you? And then ensure safety of the bystanders next. And again, doesn't look like you're going to have too many bystanders on this kind of a scene, but you want to be aware that if they wind up on scene, they could wind up falling down too. So a lot of things to take into consideration with this one. So we are going to continue on with mechanism of injury or nature of illness, or MOI versus NOI. MOI is going to be forces that act on the body that cause damage, and just the definition of nature of illness. NOI, general type of illness a patient is experiencing. Now, be careful when you use the acronyms MOI versus NOI, because they sound pretty similar. So you want to make sure that you really well state out loud what the mechanism of injury is or the nature of illness, because this is something that you're going to have to determine too for test taking purposes. Your psychomotor scenes, lab scenarios, you're going to have to state MOI versus NOI, and you could get this based on your dispatch information, and then this could change. So what that means is that you'll get dispatched for a fall. You're gonna say out loud, all right, I believe that this is potentially a mechanism of injury, so I'm going to want to consider C-spine precautions, because it sounds like the patient had a traumatic event. What you want to be thinking about too is, why did that patient fall down? So when you get on scene, as you do your primary survey and you start talking to the patient, you find out that the patient blacked out and fell down to the ground. Now suddenly it's, yeah, they fell to the ground. They might be a little hurt from that, but why did they fall down? Is this a medical emergency that caused the fall? Just something to think about. Multiple patients, obese patients may warrant additional resources. We touched on this a little bit earlier. Yeah, if you need help moving a patient, don't try to overdo yourself and overdo it. Call for the help that you need. Get the additional resources rolling. If that sometimes slows down the scene, that's something you're going to want to take into consideration based on how injured or sick this patient is. But if you cannot safely move the patient, you need the additional resources. Triage is in a chapter all to itself. We're going to discuss how you go about triaging patients. Be familiar with your specialized resources. Know what's around you, and then know what facilities are nearby and what facility the patient most needs, whether or not it's a PCI facility or a trauma facility. Just as an example. Assess the need for spinal immobilization. Not every single patient needs to be backboarded, so make sure if you do apply a backboard on it, you can explain why you backboarded that patient. And also, be able to explain why you didn't backboard that patient if you choose not to do that. This is something, again, that's kind of changing in the world of EMS. 10 years ago, everyone that had a trauma injury was backboarded. We found out that doesn't necessarily help the patient. In fact, sometimes it can make it worse. So just make sure you, again, based on your assessment, make the right choices for your patient. Moving on to standard precautions, your first priority is your own safety, always. You come first. If you are not able to perform your job because of an injury that you just sustained, now you've made things worse for your partner and your team members. So your safety comes first, followed by your partner, and then the other EMS team members, bystanders, and then going on in that order. Treat all patients as potentially infectious. You're going to wear your gloves. You're going to wear your eye protection. We usually don't have to push too hard on people wearing gloves. That's usually pretty standard. Everybody puts on their gloves. Where we do have to push people is to wear eye protection, especially on things where you know that you could potentially get exposed. The big one would be intubation. A lot of people do not wear eye protection when they go to intubate. It's just something that's kind of not thought of, and it goes to the wayside because usually you're in that circumstance where somebody needs to be tubed and it's a pretty serious situation. Then wear eye protection where you can. There's no reason why you should get any more exposure than you need to. Yeah, wear your masks. You know, in the world of COVID, we have started wearing masks on calls. That's not a bad thing. It's going to, again, reduce the amount of exposure. Wear your gowns, and then just err on the side of caution. Listen to your dispatch notes. Yeah, it can be a pain to put these things on, but they're there for a reason. So put them on if you feel that you need them, and put them on if you do need them. And finally, here are just some examples of PPE. These are listed in your book, page 593. Steel toe boots, leather gloves. These things are just going to give you that much added layer of protection. Wearing a helmet, depending on the scenes that you're going on, heat-resistant outerwear, and self-contained breathing apparatus. They're really kind of self-explanatory. Sorry for just reading straight down the list, but these are just all good examples of things that are just going to provide you with that little bit more protection. So that's going to do it for the first video, guys. We're going to start on the next one with your primary survey. Thank you. All right, everybody. Now we're going to be moving on to your primary survey. Now that we finished up. All right, everybody. Now we're going to be moving on to your primary survey. Now that we finished up all the information that we need for your scene size up. The next part is your primary survey, primary assessment. Which the first part is going to be forming your general impression. Your general impression is going to be a pretty important part of the whole assessment process. Basically, it's everything you find out within the first minute and a half, and making a lot of decisions in that very first period of time. This is going to be assessing the responsiveness level and consciousness level of your patient. That's going to go into your AVPU, and it's going to have a lot to do with mental status, which we're going to talk about in these slides coming up, about how mental status plays a large part in determining whether or not a patient is sick or not sick, critical versus not critical. But then you're going to continue on. You're going to manage your ABCs. This is going to be the part where you're going to manage any life threats that you encounter during this process. You're going to look for disability, exposure of the patient, which is whether or not the patient has anything that they're not capable of doing that they are supposed to be able to do. That's what disability largely is. And then we're going to identify the chief complaint, life threats, manage those, make your priority decision of the patient, transport, and where they need to go, and then, again, make that transport decision. So some of the examination techniques that you're going to learn are inspection, palpation, auscultation. Basically, what you see, what you feel, and then what you can hear. So inspection is going to be just looking at the patient. It's part of the doorway assessment. It's part of just looking at the patient and seeing any life threats, anything that's wrong. Palpation is going to be you actually, the quickest example I can think of is going in and palpating the abdomen, which can be gentle but firm to try to find any kind of mass, anything that's wrong. And then auscultation, listen to your lung sounds. You're going to have a good stethoscope to perform this job. All these things will help you with your general impression, or help form your general impression. So that's going to go into your initial presentation, what you see on the patient, what their chief complaint is, how they tie into one another. It says here to make conscious, objective, and systematic observations. And then is the patient stable or unstable? And again, that's going to largely go into your transport decision and how much you should do on scene versus how much you should do in the truck on the way to the hospital. And then is the patient sick or not sick? So LOC, level of consciousness, that's something you're going to want to take into consideration as part of your general assessment. Think about it this way. When it comes to medical patients and trauma patients, that if a patient is alert-oriented and able to answer all your questions appropriately, that means enough blood is getting to their brain, enough oxygenated blood is getting to their brain so that they're able to have a full cognizant response. You're also going to, during your general impression, and that's when you're going to go over MOI versus NOI, is if you have a mechanism of injury, does that patient need spinal immobilization procedures? And be able to explain why you are going to put them on a backboard, basically, or why you do not feel that they need a backboard, or why a backboard is not appropriate. You're going to determine your priorities of care. What needs to be done first and what can wait. And then identify the age and the sex of the patient. It's going to be part of your documentation process anyways. So you got to go ahead and make sure that, that you are putting that down correctly. Treat life threats as you find them. So this is going to tie into both real life and the scenario world that you're going to have in school during assessment, psychomotor test outs. You're never going to find a life threat and move on from it and continue your assessment. You must stop what you're doing when you find a life threat, manage it, and then move on with your assessment. So what that basically means is if you have an alert-oriented patient and you see from the doorway that they are their femoral artery, it looks like they're having a femoral artery bleed. The patient's answering questions appropriately. You're not going to ignore that bleed to continue talking to the patient to find out what was their last oral intake, what did they eat last. No, you are going to stop your assessment and you are going to take care of that injury before you move on. It's kind of a common sense thing, but you would be surprised how often these things are missed during practical psychomotor test out scenarios. And then in just in real life, that's pretty simple. If you see something that's a life threat, you manage it and then you move on. When you find a life threat, along with managing it, think about what additional care is going to be needed. So when you think about a patient that's having a massive bleed like that, once you've managed to stop the bleeding, what are they going to need after that? Are they going to need oxygen? Are they going to need fluid replacement? Ultimately, they're going to probably need blood products at the hospital, right? Or replacement blood, because we know now with enough data that we no longer start 2 large bore IVs and just dump a ton of fluid into patients anymore. Because that's going to inhibit their clotting factor. So we don't want to do that anymore. We want to maintain and stabilize the patient. And that's going to be largely based on their mental status and their blood pressure. What needs to be done on scene? What can wait? So we talked about medical patients versus trauma patients. If we use that example where a patient is bleeding bad enough that you have determined that they need a tourniquet to stop that bleeding to save their life, what else do you need to do on scene versus what can be done in the ambulance on the way to the hospital? And then that goes into when to initiate transport. Generally speaking, if I've got a patient that had a bleed like that, managed them with a tourniquet, we're going to get this process moving because they need to get to the hospital pretty quickly. There's only so much that we can do on scene, and that's going to go into what kind of facility does this patient need? Do they need a stroke center, or do they need a center that's going to be able to manage trauma better, like a level 1 trauma center? We're going to take that patient to the trauma center. So assess mental status, use your AVPU scale, alert, verbal, painful, or unresponsive. The AVPU scale is going to help you determine 4 primary areas of alertness, and that's to person, place, time, and event, which we will go into. So going on to your ABCs, assessing the airway. Is the airway open and patent when you arrive on scene with the patient? Is that airway going to stay open and patent? So think about your patients that are having an allergic reaction, for instance. The airway that is patent one moment may very quickly not become patent in the next. So that's also going to go into your working diagnosis. You're going to need to memorize and learn the different respiratory patterns. So for instance, for an airway, you need to know that if a patient is snoring, there's a position problem. You may need to reposition the airway in order to alleviate any blockages, which could include the tongue, as we know, which is one of the major things that winds up obstructing an airway. Or that if the patient is gurgling, then you know that the patient is going to probably require immediate suctioning. One of our golden standards is a crying or talking indicates that the patient has a patent airway. But remember, you need to document that too. You need to make sure that you mark down that the patient's airway was patent and why you felt that it was patent. Well, patient's airway was patent because he was talking to me in full coherent sentences. So moving from simple to complex is going to be determined by the position of the airway and the obstruction, whether or not a simple maneuver opens the airway up, or whether or not the obstruction needs to be manually or mechanically fixed. So try to go from the easiest possible to the more complicated, which is if you can just reposition the airway safely, great. If that keeps the airway open and patent, perfect. But if you need to move on to more complicated techniques to open the airway, especially if there's an obstruction, you do so. So possibility of spine injury will determine how you open an airway. That's going to be your jaw thrust versus your head tilt chin lift maneuvers. Remember, one is for each. You know, if you have a patient that you think might have a spinal problem, you're not going to want to manipulate that airway by moving around the body too much. You're not going to want to move that spine too much. Mechanical. If you need a mechanical airway, that means that it's no longer a natural airway, that something is placed to keep that airway open and patent. And of course, if the patient cannot maintain their airway, you're going to use a more invasive technique using a mechanical device, such as a King LT, Combi tube if you still use them, iGel, or intubate the patient. Assessing the breathing is what you're going to move on to from the airway. 2 quick questions you need to ask yourself when you make patient contact. Is the patient breathing or not breathing? If they are breathing, how well are they breathing? Is it adequate? Or do you need to breathe for them? If they're not breathing, you're going to breathe for them, and then you're going to make the determination if they need a more invasive mechanical procedure placed like we just talked about. If you have an unconscious trauma patient or an unconscious patient that's not breathing, you're going to need to expose the chest and you're going to have to check for injuries, such as a sucking chest wound, tension pneumothorax, flail segment. These things might not be readily visible. That's why you have to expose the patient. And remember, if you have an unconscious patient that you are pretty sure is a medical patient, the reason that they're not breathing is because of a medical event, you still need to rule out trauma. So again, because these things aren't easily visible, you need to go ahead and expose the patient, make sure that you rule out the trauma. And then you're going to consider the patient's minute volume, which is how much air they breathe in and out every single minute, which is calculated by respiratory rate and tidal volume, by multiplying those together, which is going to be outlined later on in your respiratory sections. You need to also consider as part of ABC, as part of the breathing part, is the breathing rate. Like we just mentioned, where does that fall into the normal category between 12 and 20 breaths per minute for an average adult? The work of breathing. Chest rise and fall, is it equal and bilateral? That's going to go along with your lung sounds, which is going to be, again, something you're going to cover more in detail, but you need to know the different lung sounds and what those lung patterns mean. Moving on to circulation. First thing you're going to do to check for circulation is to perform your full body scan, which means looking for major hemorrhaging or life-threatening injury, managing it, checking the patient's pulse, and evaluating the patient's skin. There's going to be a big difference between doing a rapid exam versus your detailed exam, which should never take place in the field. It should take place on the ambulance after you've treated the patient, managed all your life threats. Palpating the pulse should be pretty easy to find. On a conscious adult or pediatric patient, you should be able to take a radial pulse and feel that. What you want to generally do, the rule of thumb here is to palpate and feel for a pulse for 30 seconds and then multiply that by 2. However, if you have a patient that falls out of normal parameters, you're going to want to go ahead and do the full 60-second check, unless, of course, you don't feel a pulse, in which case you're going to be moving on to a different algorithm. Normal pulse rate on average, so this is just average for an adult, is between 60 and 100 beats. Anything below 60 is bradycardic. Anything above 100 is considered tachycardic. However, not all patients are the same, as you are well aware. You've got some fitness athletes who have a normal resting heart rate in the 40s. That's normal for them. That doesn't necessarily mean that they need to be treated for that, because that's normal. That's where mental status comes into it. Are they still answering questions appropriately? They have a heart rate of 40, which is normally very concerning. but they're answering all questions appropriately to you, and they can provide their background and pretty sharp and back and forth. Generally means that, again, enough oxygenated blood is getting to their brain. Whereas you have some patients who are incredibly out of shape, and their average resting heart rate might be a little bit above 100. These are all things to take into consideration, but the average range is between 60 and 100, and that's usually the basis for most documentation purposes in terms of bradycardia versus tachycardia. You're going to want to check for the quality of the pulse. Normal pulses, like we said, should be pretty easy to find radially. Remember, if you have an unconscious patient, don't bother with the radial pulse at first. Check for a carotid pulse right away. Go with that first. Weak pulse is going to feel thready, whereas if a patient is hypertensive, has a high blood pressure, their pulse may feel very bounding and quick. Rhythm is going to feel regular, which is bum, 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 bum. Whether or not it's too fast or too slow, it can still be regular. You want to look to see if you feel any beats that are just missed altogether, or they come too early or too late. This is also going to be an indication for you, no matter what the situation is for the patient, that they should go onto your cardiac monitor. And make sure that you document these things and document any changes that you encounter while you're managing the patient. Assessing the skin to evaluate perfusion for light skin patients is going to determine how much oxygenated blood is going through their circulatory pattern and how effective that is. People who become very pale, very, very pale, could indicate a hypoperfusion problem. Now, if you have a patient of color, that might not be as readily visible, in which case you look at mucous membranes, in particular patient's lips, can help indicate whether or not they are hypoperfused, in which case you might see that their lips are blue. If a patient's lips are blue, that's a sign of hypoperfusion. You're also going to check the temperature of the patient, which can be just as simple as this picture shows, of putting your hand to the patient's forehead. And you're going to determine whether or not they're very, very warm, flushed. You're going to want to determine if they're very, very cold either. Anything that doesn't feel normal. Anything out of the normal can help you determine whether or not a patient is becoming hyper or hypothermic. Hyperthermia can indicate any kind of number of medical conditions, including sepsis, which is a major problem for a patient. And if the patient becomes hypothermic, that could indicate decompensated shock, or they are now in late stage sepsis. And finally, condition. Is the patient hot and dry, or are they hot and wet? And vice versa. Are they cold and dry, or are they cold and wet? All of those are going to indicate potentially different medical emergencies that the patient may be experiencing. So here is the tables that are available to you in your book, again, which goes through the different kinds of skin colors that you may encounter among certain patients, taking into consideration if patient is Caucasian or light skin versus patients of color. Red, white, pallor, blue indicates cyanosis. That's the one that you're going to really want to pay attention for, because that's what typically falls into exam category and is a major sign of hypoperfusion. Mottled skin, jaundice. Jaundice could indicate your liver dysfunction amongst your alcoholic population. And then again, page 600 in your book is where this is located, but part of your skin palpitation, again, hot, dry, hot, wet, cool, dry, cool, wet, in terms of shock, heat stroke. And again, those are going to go into your environmental concerns as well. So we're going to talk about how you're going to fix these problems should you encounter it. If you have a patient with poor circulation or inadequate circulation, to stay here, you're going to want to take steps to improve that. We have discussed that if the patient has poor circulation, that means that there is a problem with oxygenated blood going through the patient's system. So you're going to think about putting them on oxygen. You're going to want to think about establishing an IV and replacing any fluid loss that they have within the appropriate means, controlling any severe bleeding. Again, that's all part of your life threats. You're going to want to take care of that as quickly as possible. And then again, oxygen delivery to the tissues. This is all going to be part of the process of stabilizing the patient in their current situation and getting them to the hospital. And then finally, restoring circulation. Pretty simple step here. If you can't feel a pulse, which you're going to check for no longer than 10 seconds on an unconscious patient on their carotid artery, if you cannot feel a pulse, you're going to start CPR until an AED or manual defibrillator is available to you. But since you are a paramedic, hopefully with a paramedic or EMT partner working as a team, you will have that ability and that equipment with you. But again, as far as your AHA guidelines go, if you find a patient without a pulse, when you arrive on scene, you're going to start CPR. Follow your standard precautions. Make sure that you're wearing your appropriate PPE and follow the protocols that you guys have in place. Once you get into cardiology, you'll learn more about the different rhythms, the life-threatening ones, the ones that you can manage and treat differently in the field versus tachycardic and bradycardic. You're going to go ahead and evaluate that cardiac rhythm. You're going to place the patient on the cardiac monitor, run a rhythm strip, and it's going to be one of the coolest moments in medic school for you, I promise, is when you learn to read rhythms. That was such a cool moment for me when I realized that I didn't need any help and that I could read these rhythm strips without any assistance. That's a pretty cool moment. But then it goes into the management of that patient condition. And then oxygen delivery, depending on how you're going to give that supplemental oxygen. That's going to be your judgment call. Remember, not every patient needs oxygen. You need to have a reason for giving a patient oxygen. Again, we got to get away from this idea that, a little bit of oxygen never hurt anyone. Oxygen is considered a drug. You need to have a reason why you're administering it. And then you need to have a reason why you're giving it in the method that you are, versus nasal cannula, versus a non-rebreather, versus intubating, versus BVM. So we are going to move on to assess the patient for disability, which is going to be a neurologic evaluation. Think about disability as a neurological deficit, something that they're not able to do. You're going to start off with your AVPU, your alert. Is the patient alert? Normally alert? Are they alert when you arrive on scene, looking at you, making eye contact, speaking to you? Are they responsive to verbal stimuli? Do they only respond once you speak to them? Do they speak back appropriately or inappropriately, or just cognitively? Are they only responsive to painful stimuli? Like you have to do a chest external rub, and that's the only way to get a reaction out of the patient because they won't respond to your voice and they're not naturally alert? Or are they completely unresponsive to any verbal or painful stimuli? You're going to check their pupils. Use a pen light to check to see the size of the pupils and their reactivity. Do they become smaller then? Do they dilate? Or do they contract or constrict? Are they pinpoint pupils when you arrive? Generally speaking, that gives you an idea of potentially what might be going on. Heroin is a huge problem. Narcotics are a huge problem in the country right now. And you will run more than enough narcotic overdose patients in your career. But also the patient's pupils reactive to the light. Are they dilated? Are they unequal? Then you're going to do a quick assessment for the other neurological deficits. Can they move their arms? Can they move their feet? Can they respond appropriately? And what's considered appropriately is going to fall on your Glasgow Coma Scale, your GCS, which you've heard of, which we've all used, which is available on your book and online. You can just type in GCS and they'll bring up the score. It's a score between 3 and 15 points. Remember, the lowest possible score you can get on a GCS score is 3. So if you are cold and dead for weeks, you have a GCS score minimum of 3. 15 is the max fully alert oriented person. We as a whole, as far as being paramedics, EMTs, just the field of EMS, we are really not good at GCS scores, and it's something that you need to kind of work at. And most of the technology that you have for documenting usually includes a GCS score, in which you can work on. So you're going to continue assessing for anything grossly wrong, and you're going to document, report it, and then use that as part of your working diagnosis. Can the patient move all their extremities? Can they move them equally and with strength? Or are they weak? Are they weak in a manner that they shouldn't be weak in? Check their grip strength, and you're going to be assessing for the loss of sensation in any part of the body. In the extremity, can they feel that? And that's just it's just putting a little bit of pressure on the hands or the feet and seeing if they can feel that. Expose, then cover. Visually inspect areas being examined. So if you're checking a patient's abdomen, for instance, you're going to want to discreetly expose the abdomen so that you can see it. And again, that helps rule out trauma, for instance. You find any mass, any signs of bruising. It says here you can't assess what you cannot see. Just make sure you do this in a discreet fashion, depending on the circumstances, wherever you are. You don't want to fully expose a patient that's fully alert and oriented in front of a large crowd of people. Do things in an appropriate manner. And again, that's largely going to be based on where you are and your own common sense judgment choice. And then you're going to make, with all that you have, you make a transport decision. That's when you're going to decide whether or not the patient needs immediate transport, or you need to get the patient rolling to the hospital sooner, or if you have some time to manage the patient a little bit more on scene. Do only what's necessary on scene and handle everything else en route. And we talked about that as far as medical versus trauma patients. For the most part, most of your major trauma patients, everything that you need to do for that patient can be done en route to the hospital, and the right hospital, which is a trauma center if it's a major trauma patient. And then for your medical patients, make sure that you might decide that patient needs to be transported, but make sure you're covering your bases and doing what you need to do on scene before you leave the scene. So let's try to clarify that a little bit. I say as a broad term, medical versus trauma patients, priority patients versus non-priority patients as far as transport goes. And this is going to be something we're going to discuss here that is a little bit different from what other books and other resources will tell you, especially now with more modern medicine, modern data coming through. So here's a list of some priority patients receiving CPR. Now, I don't personally agree with this as far as the book goes. The book is saying that as a priority patient, limited scene time. A patient that's receiving CPR, as long as the scene is safe, that patient needs to be worked on scene. You cannot safely do CPR in the back of a moving ambulance, and there is nothing much more that they are going to do at a cardiac facility or a hospital during a cardiac arrest that you can't do already on scene. Now, when I say follow your protocols, that means that every place you work might have a different procedure or process to this. I can tell you I worked at one place that if we started CPR on a patient, that we would want to expedite transport to the hospital. I worked at another place where we were going to work that patient for the full 20 minutes on scene and then call into our medical director to determine whether or not we transported or ceased efforts on scene. That seems to be more commonplace than to load and go because, again, you cannot do adequate CPR in the back of a moving ambulance. But again, that's going to be location-based because some places have devices such as Lucas, the Lucas device, which can do CPR for you. Some places might have you transport CPR patients. Just understand that, again, we operate in that gray area, so it's not always going to be universally the same. But some other instance of priority patients, you have a poor general impression of them that you form up right away, going through your doorway as part of your primary survey. You say to yourself, this guy or gal is probably going to be a pretty limited scene time, and we're going to want to get moving. Unresponsive or responsive but can't follow commands could indicate a neurological emergency. You're going to want to get them spend limited time on scene. Doesn't mean you're not going to do your job and do what you need to do, but you need to probably get the patient moving a little bit quicker. Any kind of respiratory problem, major respiratory problems, such as difficult breathing, any kind of hypoxia that lasts longer than 2 minutes, so they're still having respiratory difficulties, any hypoperfusion or shock, complicated childbirth patients, chest pain patients. Your chest pain patients is what I'm kind of referring to as far as limiting your scene time, but still doing your job on scene. So if you have a patient that's having chest pain, that doesn't mean that you need to, again, get them onto the stretcher and get them in the ambulance and do everything in the back. That takes time. You have a chest pain patient. You should do a cardiac monitor, do a 4-lead and 12-lead before you move that patient onto the stretcher. Because again, you're going to need to get this information quickly because that could change. Or if you arrive on scene and the patient's having chest pain and they have a lethal rhythm that they're in that's not going to be sustainable, you can treat them on scene as quickly as possible with the right cardiac electrical intervention, which again, you'll get more into as you get into cardiology. So it says here, a suspected AMI with EKG showing STEMI. The only way you're going to find that out is if you do the cardiac monitor on scene. So that kind of gets to what I'm talking about. So on scene, chest pain, or you have a suspected AMI, if you have the EKG showing STEMI, then you know that you've done your job. You've probably taken a set of vitals along with that, and you've done the cardiac monitor. After do a suspected stroke. Again, you're going to suspect a stroke after doing your full assessment of the patient on scene and checking for those neurological deficits and that disability in the patient. Severe pain anywhere where the patient's reporting it. Any multiple injury patient. So that's your trauma patient. Multiple injuries means, hey, we need to get this patient moving. There's only so much that we can do for them. The hospital is going to be what they need to take care of them. Any abdominal injuries, severe hypotension, very, very low blood pressure. If they can't move at all, that's a neurological problem. Or they have an EALT, which is an apparent life-threatening event. That goes along very much with pediatric patients. So make sure you read your book and you go over the priority patients, and then you make these decisions, because whether or not you transport a patient immediately versus you work them on scene, at some point you're going to have to defend yourself as to why you stayed on scene or why you didn't stay on scene, why you moved too quickly or why you didn't move quickly enough. You just need to be able to document really well and to be able to defend your actions as to why you did what you did and why your team did what they did. That's what's going to be really important. Anyways, guys, that's going to end up this section. The next one is going to be history taking. All right, guys, we've gotten through our scene size. All right, guys, we've gotten through our scene size up. We've made sure that we got to the patient safely. We got the patient off scene safely, and your team is safe. We've gone through a primary survey. We've managed all major life-threatening issues that we've encountered, and now we're going to move on to the history-taking portion. This is the part where we're going to get information that surround the incident or surround the patient's chief complaint. And what I mean by that is that you're going to get information from the patient that's going to help explain why the patient is in the condition that they are, or maybe get information that's going to explain why the situation may have gotten worse or may have gotten better. You're going to ask open-ended questions as opposed to closed-ended questions. Open-ended questions are going to be very good for information seeking because it allows the patient to explain in their own words what's going on and provide you with more detail, as opposed to a closed-ended question, which does have its place, but closed-ended questions are more yes or no answers. So you're going to wind up using both of them for management of patients. Avoid leading questions, which means don't lead the patient or ask the patient things that are going to lead them in one direction or another. The open-ended questions allows them to explain themselves, where leading questions might get them to go down a direction that you want them to go that might not be which might not lead you to the right conclusion. Ask age-appropriate questions. Largely, you're not going to ask a toddler the same questions that you're going to be asking a geriatric patient. We'll talk about that more. Be patient. Always remember, this is not your emergency. This is the patient's emergency. And no matter how mundane you might think this is or how non-emergent this is, it doesn't matter. That is not your emergency, or you are going to have to be patient, ask all the questions, and do your full assessment on every single patient. And then use opportunities for patient teaching. Well, as they're explaining circumstances to you or certain things that you suddenly realize may have contributed to making the patient feel this way, you can interject with some gently worded teaching moments where you can kind of explain, well, hey, if you did this, this might help. Sometimes that might not be well received, but you should still endeavor to give teaching opportunities when they become available to you. So, name and chief complaint. These are going to be your priority pieces to get, because at the end of the day, the idea here is, let's say the patient goes unconscious. As long as you have their name and you have why they had called 911, you at least have some basis to go on for your treatments, and then you can explain to the hospital, here's what they gave us. You give them a name. Sometimes they will have that name of the patient on file, so they have a little bit more history that they can get from that patient there, and at least you can tell them what the patient was saying was wrong before they went unconscious. So that's why these two things are very, very important. Now, you can get the chief complaint. Sometimes patients will have their licenses on them, which will allow you to get their name. You can't always depend on that. But these two are the first two things. And then get more information basically from there, and which is the whole point of the assessment, right? We're going to talk about all the items that you're going to want to get. We're going to talk about your sample and your OPQRST as well. So some quick techniques for history taking. This is going to kind of go back to the initial lecture that I did on EMS systems, but how you look and how professional you look, it matters, because that patient is making snap decisions about you, and if you look like a slovenly, riposte, they're not going to trust you. They're going to equate your professional or lack of professional appearance on the treatment that they are going to receive. So please come to work groomed, take a shower. You're going to be standing in close proximity not only to the patient but to your partner, and if you stink, they're going to be able to tell that pretty quickly. So please project a good attitude. That's easier said than done sometimes. You're going to show up on scene, you got life events going on, things in your normal everyday life that might not be super positive or super great at that period of time. You need to kind of put that behind you while you're doing patient care, because perception is key. If you are, I think the book uses the example, if that, you are unhappy, you will appear sad, and that patient's going to pick up on that demeanor really, really quickly. So always show up to work, show up at patient side. You don't have to be super duper happy, smiling, but you need to give the air of professionalism at all times. So you're going to want to take notes, especially as a new medic. It's kind of hard to keep track of all the information the patient is getting to you. And quite frankly, you're going to have to document this stuff anyways. So you want to let the patient know that you're going to be taking notes. The reason being is that they know that what they're saying is important. And quite frankly, it also lets them know that you're not just scribbling or doodling in a notebook and kind of ignoring them, because eye contact is so important. If you're looking at a notebook while you're writing down what they're saying, you're not making eye contact. But if you let them know that, hey, I'm just going to be writing down what you're saying, they won't think anything other than that what you're writing down is something that's important. Position yourself at eye level. Don't stand over a patient looking down on them. It just doesn't give the right perception. It gives an air of kind of almost aggression, and then maintain good eye contact, like we just said. Be polite. Introduce yourself. Introduce your partner, and then make sure you identify that you work for EMS and the agency that you work for, so there's no misunderstandings there. This set talks about being familiar with cultural groups in your area. Wherever you work, there's going to be different nationalities, and working amongst them, you might have accidental misunderstandings. As long as you are aware of the cultural groups in your area and how their belief systems work, you'll have a better experience overall. And again, you avoid doing anything that might be considered rude. So be familiar with the cultural groups in your area. Case in point, where I worked at in Iowa for a couple of years, we had a very large Sierra Leonean population. And we also had a very large Muslim population. And knowing how their cultural systems work, it was important to me so that I didn't do anything to offend anyone. And that way it always shows the level of respect that other nationalities do deserve. And then finally, you're going to ask about the patient's feelings. This can get a little more sensitive, but you're going to have to ask them if they're tired, if they're depressed, if there's anything wrong or anything, as the book talks about, anything that can be replaced with denial. But it's going to be an important part of gathering the patient's health history is to ask them how they're feeling, just really plainly. You're going to communicate empathy, offer reassurance to the patient. Don't make any false promises. Read nonverbal cues. Make sure you're paying attention to the patient's body language as well. If they are having pain and they're exhibiting signs of pain, that's part of the whole assessment process. That's something that you're going to want to write down and take into consideration when they're talking about their pain scale. Encourage dialogue. You want to have a back and forth with this patient. That's called developing a rapport. Don't just rattle off all the simple questions that you need for your computer tablet for your documentation. Have them elaborate. Go into a dialogue with this patient. Treat them like a human being. And then you want to avoid some medical terminology. You don't want to ask somebody questions that they're not going to understand or not be able to answer. You want to make things really simple for them. They are not medically trained, so you can't expect them to understand every single medical term that you have learned and that you know. You don't want to make them feel bad for not knowing that either. So just use simple terms that they can understand. So let's talk with dealing with sensitive topics for a little while. Social history talks about how this is not typically gathered in a pre-hospital setting, but it should be. This is questions about sexual history. For some patients, this is going to be important things to know. Not everybody needs to know everything about a patient's sexual history, but there are certain patient demographics where it's going to be important. This is also asking a patient, do they use tobacco? Do they use drugs? Do they use alcohol? Anything that goes against kind of what the fabric of society would say would be good. This is going to help you provide information about the patient's overall health and also help you find some risk factors that may have contributed to the patient's current situation, current emergency. So alcohol in particular and drug use, both alcohol and drugs, depending on what they've taken or how much alcohol they have had, can hide the signs and symptoms of a major medical issue. These patients are the ones that we become complacent on at EMS as a whole in general because we run on these so very, very often. And a lot of times it is just for the alcohol complaint. These patients can also sometimes be less than kind to us. That's why we tend to get complacent on these calls. I had a really great medic that I trained with that referred to alcoholics and drug abusers and the ones that you go on regularly enough that you know them by their first name. These are career killers because what's going to happen is you're going to pick up one of these patients. It's going to be 3, 4 o'clock in the morning. You've had a very busy shift and you're picking up this guy again and they're acting like a jerk and you're going to not take vitals or you're not going to listen to their chief complaint or you're not going to check that blood sugar or you're not going to do that cardiac rhythm when he tells you that his chest is hurting. And you're going to arrive at that hospital. You're going to drop the patient off and say, yeah, so-and-so is drunk again. And they're going to be having a massive MI or their blood sugar is going to be low. Great doctor I worked with too said that alcoholics and drug users also have medical emergencies and they tend to have them more often because they've destroyed their bodies with their habits. So please do your job as much as you can every single time. And when I say as much as you can is that when you assess these patients, sometimes the information will not be reliable and sometimes you might not be able to ask all the questions because they're not going to answer them because they're not being very kind to you, for instance. But do your job, do the best you can, always. Remember that history can be unreliable and always remain professional. Continuing on, like I mentioned, some patients are going to need you to ask them some questions, some pointed, direct questions about their sexual history. Make sure that you let them feel secure, so ask them these questions in a private environment, such as the back of the ambulance, and don't be afraid to ask some people to leave the room so you can ask those questions. Don't interject your opinions and biases. The patient's life is their own. They don't go through the world the same way that you do, perhaps, so just don't offer any of your personal opinions or biases ever. And then, of course, treat them with compassion and the respect that they deserve as human beings. Unfortunately, you're going to run on a lot of domestic violence, assault, and sexual abuse cases, more so than anyone ever should. And it is a very unfortunate call to run on. These ones can really get to you as a provider, as someone who provides compassion and empathy to patients. But you are a mandatory reporter, so you're required to report your findings. Make sure you look for the clues on scene. And always call law enforcement if you feel that it's necessary to get them involved, especially if, as a mandatory reporter, if you do have a high suspicion of sexual assault or domestic violence. And then maintain evidence per protocol. And there's lots of different protocols that can go into that. Case in point, places I've worked before, if you had a potential rape victim and they had clothing on, you need to make sure that clothing comes with the patient in one way or the other. And the other one was that if the patient asked if they could take a shower or clean up, you got to convince them not to because there could be DNA evidence on that patient, which could help eventually catch the bad guy. So handling physical attraction to patients. This is never appropriate. It should never be done. If a patient starts making advances on you, you need to stop them immediately. Maintain a professional attitude. Make sure the patient is aware that you're only there for professional reasons. Keep somebody in the room with you, and keep somebody in the back of the transporter unit with you. If you got a patient acting like this, you never know what kind of accusations might be hurled at you later on for both men and women providers. So just make sure that you have somebody else riding in the back of the truck with you, the back of the ambulance. I say truck a lot. I mean the back of the ambulance. But make sure you have somebody riding back with you, even if it means you got to wait a little while for another service to come on scene and then write in or let your supervisor know. But don't put yourself in a compromising position where it's going to be your word versus theirs. And of course, at all times, you need to ensure the patient's confidentiality. Be familiar with the laws of the area. You need to know your HIPAA laws, your state laws. There's no reason to ever air out a patient's medical information other than to the doctor or the nurse that you arrive on the scene at the hospital for. And quite frankly, if you reveal any of these things, you will most likely lose your job and you most likely will face a lawsuit. And if you actually did it, you'll deserve it. As often as possible, interview patients in a private setting like we talked about. Get information that the patient may be reluctant to share. That's going to be how well you develop a rapport with the patient. That's going to be you making sure that patient feels secure and safe and in an environment where they might be more forthcoming, which is largely going to be one that's private, just between you, the patient, and your partner. And then again, don't hesitate to ask somebody to step out of the room if there's information that you need to gather that might be a little sensitive. So third-party usage. There's going to be circumstances you're going to run on calls where patients not going to be able to provide you information. This is talking about patients with dementia, altered mental status for one reason or the other. You might need to ask other people on scene for information. It says here, the further from a primary source, the more inaccurate information becomes. So you need to gather that information on scene rather than wait. Family and friends, just remember that the information that you're getting from them may be filtered, especially if the patient was doing something that there are certain legalities that may have been breached. So just remember that the information may be filtered to some extent, but you still need to get some information. A little bit of information is better than nothing at all. But they very well could at least tell you what the patient's chief complaint is. Family's really good about knowing patient history sometimes. We're never going to deal with absolutes, but if family member is taking care of a patient, chances are they'll be able to get you some information on the patient's history and the current health status of the patient. So this one's going to be important too. If you are a service where you arrive second on scene or third on scene to another group of first responders or law enforcement, they don't just ignore them and go straight to the patient. Ask them what they saw, ask them what they have, what information they have gathered from the patient. You will do yourself a whole lot of favors and make your career a lot happier if you get along well with the other services in your working area. Get to know the guys that you're going to be working with, the fire department, law enforcement, and don't ignore them. Make sure you get information from them first. It's a professional courtesy. You arrive second on scene, you have fire department, paramedics, EMTs that have been on scene for a few minutes. Don't just walk straight to the patient. Go up to whoever's leading that scene and ask, hey man, hey ma'am, what's going on today? What's the situation? And let them tell you what they have found so far. Plus, it's professional in the manner that the patient's not going to feel thrilled about answering the same questions another time. So if you charge right in and go straight to the patient and start asking the same questions that the patient has already answered, now they're going to start to get irritated. So you don't want that to happen either. If you're taking a transfer out, you work for an EMS service that deals mostly in transfers, or you wind up running transfers, go over the patient's paperwork. This is going to be good for you to get their history down, and it's going to be good to, quite frankly, learn some of the medications, especially as a new medic. You're not going to know what all the medications are when you get done with paramedic school and you're on your own, because there's so many medications out there. Become familiar with the patient's history and medicine that they're taking. And then, of course, evaluate your sources for reliability. So cultural competence, we live in a diverse world, and that is a wonderful thing. But you need to understand the differences of some cultures and how they approach things, because your morals might be different from somebody else's morals, and that's not to say that anyone is wrong, but you need to understand other cultures. So some common barriers to communication are all the following on this list. So we're talking about like race, ethnicity, age, gender, language. I could read down the list, but you can see it very, very well. These are things that you're going to need to understand that are going to be approached differently or look upon things differently. So respect the ideas and the beliefs of the different cultures. And again, that's going to be up to you to kind of understand the area that you work for and the diverse cultures that are in that area that you work for. This one says consider dietary practices. Some cultures have diets that are really not good for you when you think about it in terms of the approach for health. We're talking about high salt content. We're talking about a lot of sugar, things that could lead to high blood pressure, diabetes, or diabetic concerns. As always, you need to obtain consent to treat both the patient to treat the patient, or obtain consent from an elder or an adult or a parent to treat pediatric, for instance. And then, of course, you're going to provide the best possible care for all patients because all patients deserve the best from you. Research prevalent groups in your area. Again, you arrive at when you arrive or you get hired on in a certain area, you should try to, during your orientation period, because hopefully you aren't just thrown straight into an ambulance or to a fire rescue unit and sent out to go save the world. Hopefully you have a training period of time. I'd be very concerned if you didn't, but that's when you need to find out about what kind of groups are in your area. And then, of course, as always, be polite and be professional, show good manners. So if you wind up running on a patient and you do not speak the same language, utilize an interpreter. There's a lot of great apps on your phone that can help with that. And if you're feeling particularly ambitious and you live in an area where there's a large foreign language speaking group, learn that language if you want to. That would be, that's probably the best case scenario if you're able to do that. But identify an interpreter, use a medical interpreter if possible. Some hospitals usually have someone on standby for at least some of the world languages. And then consider, of course, the perception of your own body language, your hand gestures, and again, making sure that you are being polite and acting in a good manner. So special challenges in history taking. So you got your two different kinds of patients. You got the ones that talk too much, and you got the ones that won't talk at all. So with the overly talkative patients, when you can, politely interject and ask questions to elaborate on the information that you need that is more relevant to the situation. And then sometimes with overly talkative patients, that's when you kind of need to switch up to your closed-ended questions with simple yes or no answers for the most part. And then on the opposite of that, we got our patients that aren't very talkative or very, very quiet. And those you want to encourage more open-ended questions, which kind of forces the patient to open up and to have to speak onto the situation or to speak to the question in more than just one or simple yes or no kinds of answers. So your patients that are anxious, you should expect this from all patients that are sick and are injured. They call 911 because they feel they're having an emergency, so anxiety is probably going to play its part in just about every patient that you run on. It's one of the reasons why I think anxiety is one of the worst field diagnoses that you can make in the field, because so many providers immediately run to, oh, it's anxiety, it's anxiety. If you have a patient having a heart attack, they're going to be anxious. You have a patient that's been shot, they're going to be anxious. You have a patient having a stroke, they're going to be anxious. Anxiety can be one small symptom of a very large problem. So please don't be dismissive of patients and just chalk things up to anxiety. For God's sake, do your job and do the full assessment on every single patient, and don't just dismiss things as anxiety until you've arrived at that conclusion based on eliminating all other possible situations. But again, expect your patients to be anxiety, to be in a state of anxiety. The fact that you arrive in a large vehicle coming lights and sirens and there's suddenly a whole bunch of people bursting into the room, understand that just by being there may increase anxiety. But as long as you present yourself in a professional manner and you start talking to them kindly as another human being, as an adult, they may start to calm down. Their anxiety may start to lessen. And then you've got patients with that are exhibiting signs of depression, whether or not it's situational or chronic, whether or not that is something that they deal with on a regular basis or something that is acutely causing the depression, such as, for instance, loss of a family member, loss of a loved one. And then, of course, there are people who deal with depression on a daily basis. And then anger and hostility. People who are having different kinds of medical events may be angry. They might not be very kind to you. It might not be personal. Please don't take it personally. You shouldn't take anything that a patient says against you personally. Just, again, make sure that scene is safe, that the patient, if they're a little angry, that if they start becoming hostile, that's when you might need to consider leaving the scene and possibly getting other services involved. Don't put yourself in danger. Again, remember that just because the scene is safe one moment doesn't mean that it's going to remain safe. So if you need to retreat, get the police involved, and then once the police clear it, you can proceed back on scene. Continuing on, confusing history, bizarre behavior. Consider the fact that a medical reason may be causing the bizarre behavior. We're talking about your diabetics, your drug use, toxic environment, patients that are having a stroke or some other neurological event. That might be the reason that the patient is behaving in a bizarre manner. And confusing history is, gather all the information you can. Nothing is worse than when you obtain a patient history, you think you've gotten all the information that you need, and then you arrive at the hospital, and then the doctor, the physician walks in, and suddenly the patient starts talking about things that they never offer to you. That was incredibly frustrating because it makes you appear incompetent. So just make sure that you clarify those points if they're offering you bizarre or confusing information, that you just try to clarify a little bit as much as you can. One of the questions I always like to ask before I'm finished with a patient, before I finish transferring care, is there anything else that we need to know? Is there anything else that you have to offer on the situation? And if they say no, then you did your job. And then be aware for any sensory developmental challenges. Not everybody is up to the same level of education. Some people can have some intellectual challenges. Don't assume that you won't be able to get a history from them, but just, again, remember that you might not get a full story. And then, of course, you've got patients with, hearing issues, poor visibility, patients who are blind, and you just need to make sure that you take those factors into consideration as well. And speaking of managing age-related considerations, Okay, guys, managing age-related considerations. Talking first about pediatric patients. You're going to want to try to include the child up to about 3 to 5 years as much as possible in the history-taking process. They should be able to provide a few answers as to what the problem is. But for the most part, you're going to be relying on the parents or the caregiver to provide most of the information about the pediatric patient situation and current health issue. Especially in neonates and infants, you're going to want to also include, along with the information about the pediatric patient's medical problems, take into any consideration any of the issues that the mother might be having as well. Up until that point in time, you're going to want to ask questions too in neonates about any pregnancy-related issues that happened, or if there was any congenital defects or any kind of issues that came up stemming from the pregnancy. And again, you're going to want to ask about the mother, include the mother's health along with it as well. But again, so when you get to a 3 to 5 year old, you're going to want to start to include them more in the history-taking process. And when you get to an adolescent, you're going to have them provide the majority of the information for the medical concern that the patient is having. Getting back to the 3 to 5 year old patient or the infant patient, be sensitive. Patients, parents, the caregivers are going to have a lot of fears, potentially, depending on what the situation is. And more often than not, people tend to run to the internet and try to gather as much information as they can. And the internet can induce absolute panic, fear mongering in parents. The book uses a really great example about febrile seizures. Febrile seizures happen in pediatric patients. That doesn't necessarily mean that they're going to develop a seizure history. But if you go online and you quickly Google search right now causes of seizures, you're going to get some pretty horrifying results from that search, a list of things that could cause it, including brain hemorrhage, for instance, which is absolutely terrifying. Pediatric patient, adult patient, but you're going to want to listen to what they have to say along with conducting your full assessment. Pay attention to your parent-child relationship. This could tell you a couple of things. Generally speaking, pediatric patients are going to want to stay near their caregiver, their trusted place, their loved ones, and a pediatric patient that is readily and willing to disregard the caregiver and go straight to the paramedic. That's a sign of concern, not necessarily meaning that the parents are being abusive or that there is a problem of neglect, but that might indicate that the patient is very seriously ill. But again, of course, it could also mean that there is a possible situation of neglect or abuse. So it's, again, something to take into consideration. And then, of course, make sure you gather an accurate family history as much as possible from those that are able to give you that information. Moving to the other side of the pond, we got age-related considerations amongst geriatric patients, which is going to provide you with a very large range of medical and trauma conditions that you probably won't see in the average adult, adolescent, middle-aged person. Because again, as you get older, you tend to develop more medical issues, and some of those medical issues can really compound a traumatic incident. So the average 20-year-old who falls over isn't as likely to break their hip as the 86-year-old that falls over that's on blood thinners that could break their hip. And if they're on blood thinners, that could potentially really compound the issue. So accommodate sensory losses. As they get older, people tend to lose their hearing, tend to have poor eyesight. Be aware of that. Understand that any kind of geriatric patient you run on could have more than one problem. We're talking about patients you're going to run on that are going to be having let's say, a cardiac issue, having chest pain, shortness of breath, abdominal pain, nausea. There could be multiple problems, multiple chief complaints. And then, of course, you know that any geriatric patient with medical issues is probably going to be on a very large list of medications, all of which working with one another or against one another, especially if there's been any medicinal changes instituted by their doctor recently, that could also result in an issue. Symptoms may be less dramatic. So the example I like to use a lot is the 86-year-old female complaining of abdominal pain, just a tummy ache. And then you come to find out that the patient is having a massive inferior MI, or just a massive MI in general. The symptoms aren't necessarily going to be, I'm having crushing substernal chest pain that's radiating into my jaw and then down my left arm. It's going to be, sometimes it could be something much less dramatic. That they might be feeling a little nauseous, for instance, and they might be having a AAA or an abdominal aneurysm. Just be aware of the fact that the symptoms might not add up with the vitals and might not add up with what the patient is saying is wrong. And then consider a functional assessment on their mobility, their upper extremity function, which is basically amounts to a neurological test. And then, inquire the activities of daily living. How active is the patient, or how sedentary are they? So now we're going to start talking about your responsive medical patients. These are the ones that you're going to be able to do the full assessment on. Starting, of course, like we said, you're going to get the patient's name and their chief complaint. Why they call 911 in the first place. You should use quotes when you're documenting this, but you should put this down in the patient's own words, exactly what they said, what the problem was. Determine the patient's alertness. That's your APU scale. And you're going to have them start elaborating on that chief complaint. That's when you're going to go into a series of questions to have them explain more about what's going on with your open-ended questions. And then, of course, look for your clues on scene. Anything that could possibly compound the situation, be making things worse or better for the patient. So when we talk about that, we're talking about your OPQRST and sample. These are the questions that you're going to ask for the history of illness, and you can ask these for trauma patients as well, again, as long as they're responsive. But for the purpose here, we're talking about medical patients. So patient has a new onset of nausea. You're going to go into your OPQRST, onset. When did this start happening? Palliation, provocation. Is there anything that you've done that makes this better or makes this worse? The Q, the quality. Can you describe how this is bothering you? Can you describe what you're feeling per se? R is radiation. Does that pain or discomfort go anywhere else? Or are you having any other problems? I like to ask this: is there anything else bothering you when it comes to a patient that's maybe not experiencing pain but is just not feeling well? Just say the R part is just a good part to say, is there anything else bothering you? And then they'll say, hey, I'm having abdominal pain, but yeah, I guess I'm also a little nauseous. It's also making me feel a little short of breath. It's just an example. And then severity, because we love scales. Scale from 1 to 10. 10 is the worst possible pain you could possibly imagine. 1 1 being very little discomfort at all, where would you put your pain scale on? You're going to unfortunately get a lot of times everybody feels that their pain is 10 out of 10 or 20 out of 10, but take that with a grain of salt, and also look at the patient too, and look at that, again, their body language. Is their body language indicating that they're having any pain at all? And then the final question is the time. So when you got your onset, you can say the time. Did this come on suddenly, or has this gradually gotten worse over a period of time? Is there anything that has gradually made it better or gradually made it worse too? And then, of course, your sample, which is signs and symptoms. So what exactly is wrong? What are we seeing? What's the problem? What are they saying is the problem? A, allergies. What kind of allergies do you have? What kind of medicinal allergies are you aware that you have? Medications. What medications do you take? And that includes everything. Anything at all, any medication that you take with regularity or that you've taken today. P is past pertinent history. What kind of medical problems do you have? Have any of these medical problems been an issue recently? The L, last oral intake. This is the question that everybody kind of seems to gloss over, but this one's going to be really important when you're dealing with diabetic patients, for instance. And the other reason why, even on a critical patient, that this is going to be important to know is because anesthesiologists are going to be looking for that as far as when they have to put the patient out. They need to know whether or not there's going to be a potential for aspiration. And then events leading up to this call. For instance, you've got a chest pain patient. So what were you doing when this chest pain started? There's going to be a difference between a patient that was sitting on the couch watching TV and suddenly developed substernal chest pain versus the patient that was out mowing the lawn and doing a whole bunch of yard work that developed chest pain gradually while they were doing that, and then they came in and sat down. These are all important questions to ask. Now, a question we do get a lot is which one needs to come first, the OPQRST or the sample? And really, when we talked about you developing your own style of assessing a patient, this is part of that. Really, it's going to be either or, just as long as you wind up consistently following the same pattern. That way you make sure that you ask all the questions, because these are all important. I will tell you, for my my career, I have always started with OPQRST and then gone into sample. The reason being is that OPQRST, in my opinion, immediately addresses the patient's chief complaint, their concerns, why they called in the first place, I'm sorry. Versus the sample, if that patient is having severe pain or severe shortness of breath, for instance, which you're going to be managing, I hope. But if you go in and they say, oh, I can't breathe, and you're asking them about allergies or medications, that's not addressing why they called 911. So that's why I always went with OPQRST versus sample. And I can tell you right now that a really great medic that I deeply respect, he's a critical care paramedic working here in the Tampa Bay area, he always goes the other way. He asks sample first and then goes into OPQRST, because as a critical care medic, allergies and medications and the history are all really important for him to know during these transfers of these patients, these very critically ill or injured patients. These are all important things that he needs to know. So just as long as all the questions are being asked, that can all fit into your style of answering. But for the sake of it, just learn all of them and make sure you ask all of them. So again, one of the first questions you're going to ask the patient's name, you introduce yourself, you're going to try to get into their what's going on today. What made you call 911 is an excellent way to ask it. I usually ask patients, so what's going on today? What seems to be happening? And then take into consideration if the patient's behavior isn't appropriate for the setting. Some things to consider is maybe there's a lack of oxygen, that they're hypoxic, an underlying medical issue that isn't necessarily respiratory, low blood glucose or hypothermia, depending on the location and where you're at. Consider a psychiatric emergency or drug or alcohol use as well. Inquire as to the current health status. So how have you been recently? Is this something that's acutely a problem, or has this been something that's gradually beginning worse over time? There might be a lots of unrelated piece of information. That's where the patient might start going into a long, lengthy story about all the things that are causing problems. And remember, that's when you need to gently interject and try to clarify some points. But tie together their history with the history of the current event. Get that past pertinent medical history that could tie in exactly with what the situation is why they call 911 in the first place. Make sure you focus also on environmental and personal habits of the patient. Your environmental concerns. Especially if you got someone who's feeling dizzy, short of breath, and it's down here in Florida, it's 90 degrees out with 100% humidity every day. That environment may have played a factor into that if they've been outside all day. And personal habits of the patient, are they a chronic smoker, for instance? Do they have a problem with alcohol? It's when you're going to get into your sensitive topics too. So examples of some questions, like we said before, when you get to pass into your sample, signs and symptoms, what prescription medications do you take? Are you allergic to anything? Are you allergic to any medications? Do you drink alcohol? Do you drink beer, wine, cocktails? Generally speaking, I'll ask, do you drink alcohol regularly? Oh, what do you drink? Beer, wine, cocktails, vodka, liquor, whiskey? And have them go into that. I've even asked, you can ask them gently, would you say that you have a problem with alcohol? Again, that's when you're going to be getting into your sensitive topic, and there needs to be a reason why you're asking that specific question, is that maybe ties into what the problem might be. And then you can ask them, hey, do you smoke? Okay. If they say yes, how often do you smoke? What do you smoke? Do you smoke cigarettes? Do you do chewing tobacco? Do you smoke marijuana? Remind them, hey, I'm not the police, I'm just here trying to get just some more medical information. And then, based on that information, that's when you decide what needs to be going into more depth. What do you need to follow through with and ask? So, Continuing on, getting a family history, you're looking for patterns and risk factors, potential disease processes that maybe travel in that family history, in that line, particularly any congenital heart defects, any heart issues that can run in families. But just make sure that with anything that it kind of relates to the patient's current medical condition, because you don't want to go on a tangent that's somewhat irrelevant to what the patient's situation is. And if it goes too far out of the way, the patient might be annoyed while you're asking all these family questions and not addressing their concerns. So for a social history, take into consideration their occupation, whether or not they're around poisonous fumes, chemicals, if they work in a toxic environment. If your patient has chronic respiratory problems and you find out that they've been a coal miner working in the coals of West Virginia for 40 years, that could be a contributing factor as to why they have respiratory issues. The environment indicates lifestyle, things that they're chronically exposed to as well. Their travel history may be relevant. Best example I can think of is in 2015. We asked everybody who had a fever or wasn't feeling well, hey, have you traveled out of the country recently? In particular, have you traveled to West Africa at any point in time? Because there was a massive Ebola outbreak. And in fact, here in the Tampa Bay area, one medic in that time that I know of that actually works for the school asked that question, and the patient said, who had a fever, and said, yes, I just got back from Guinea. And I believe at that time, Guinea had a pretty bad Ebola outbreak, and he wound up having to get quarantined after that for a little while and tested. And thankfully he didn't have it. Neither did the patient. Questions regarding the diet might be appropriate. We kind of talked about that earlier, that some patients eat foods with regularity that are high in sodium. That could lead to high blood pressure. Patients that are obese, tend to eat things that are not as good for you. Just as a generality, high sugar content diets. That's a perfectly valid question to ask, especially if the patient has any history of diabetes or anything. Continuing on with the past medical history. This should include any medications and dosages in specific. If you can get access to those medications, if you're in the residence, you can get eyes on them, great. If the patient lets you, bring them with you. If the patient is unconscious, bring them with you. That way, there's no mistake or any accidental miscommunication to the hospital staff. Ask them about their allergies. Do you have any allergies? They tell you everything. Like, do you have any medicinal allergies specifically? And if they say yes, they do, ask them what they are, and then ask them what happens if you take this med. Because there's a difference between breaking out in hives versus my throat swells up and I stop breathing. So make sure you go into detail on some of these questions too. Create that dialogue. Did you have any childhood illnesses and immunizations? Is there anything that from your childhood illness that has contributed to your daily life now? Have you had any recent adult illness diagnoses? Any past surgeries? Any recent surgeries? What was it for? And how has the post-surgery been going? Past hospitalizations and disabilities. Is there anything that you can't do? So, for instance, if you run on a patient that's got chronic weakness on their right side, and they tell you that they've had strokes before and that this is now a disability of theirs, if you run a neurologic exam and the right side is weaker, that's because it's normally weaker now because of the previous incident. That doesn't necessarily mean that there is an acute stroke. So that's, again, something that you're going to need to delve into and make sure you have all the right information. And then, of course, the patient's emotional affect will provide insight into their overall mental health. And that's another, when we went back, we were talking about some questions that you need to ask the patient. Are you tired? Are you depressed? Are you having issues with depression? Is this acute? Is there something that recently happened to trigger this? Or is this something that's been going on for a while? And then, of course, determine whether the patient has ever experienced a problem. Yeah, has this ever happened before? Whatever the medical situation is, has this ever happened before? And then another good follow-up question to that is, how were you treated the last time this happened? What did they do for you in the past? So all good questions. And again, you got to continue that dialogue. You don't just need to ask the one question and then leave it at that. Get some more information. Now, on your unresponsive patients, it's going to be completely different.